All right, let's jump right in. We're going to tackle a topic that every single clinician really needs to get a handle on: vitamin D deficiency. Our goal here isn't just to list facts, but to really connect the dots from the basic physiology all the way to making smart, safe decisions for your patients.
So here's our game plan. First, we're going to lay the foundation: how calcium and vitamin D are supposed to work in harmony. Then we'll see what happens when that system gets out of whack. We'll dig into what that means for bone health, walk through how to diagnose it, and wrap up with the essentials of treatment. It's a straight shot from the science to the clinic.
Okay, so let's get started. To really get what goes wrong with a deficiency, we first have to appreciate how the body is designed to keep its calcium levels in this incredibly tight, stable range. It's a beautiful system. Think of these two as a team, a dynamic duo. Vitamin D's main job is to go to your gut and help you absorb calcium from the food you eat. It's all about bringing calcium in. Parathyroid hormone, or PTH, is more about holding on to what you've got. It tells the kidneys not to waste calcium, and in a pinch, it can pull calcium from your bones. They're constantly working together to keep things balanced. And this brings us to a huge clinical pearl right here. When you suspect a patient is deficient, this is the lab you order: the 25-hydroxy vitamin D. Why this one? Because it's the storage form. It gives you the best, most stable picture of the body's total vitamin D reserves. It's the one that counts. So how do we even get this stuff? Well, it's a pretty neat 3-step journey. It all starts in the skin, thanks to sunlight. From there, it makes a pit stop in the liver where it gets converted into that storage form we just talked about. And for the grand finale, it goes to the kidney to get activated into the form that actually does the heavy lifting in our gut. Skin, liver, kidney. Simple as that. Okay, so that's the ideal situation. But what happens when you don't have enough vitamin D in the tank? Well, it kicks off a very predictable and kind of damaging chain reaction. Right away, the very first domino to fall is vitamin D's main job. Without enough of it, your gut just can't pull in calcium from your diet efficiently. The front door for calcium coming into your body is basically locked. And it's simple cause and effect, right? If you're not pulling calcium in, the levels of calcium floating around in your blood start to drift downwards. And your body notices this instantly. And here's the body's emergency response. The parathyroid glands sense that drop in calcium, and they go into overdrive, pumping out PTH. We call this secondary hyperparathyroidism. Now, PTH is trying to be the hero. It saves calcium in the kidneys and yanks it from the bones. But this compensation, well, it comes at a serious cost to the skeleton over the long run. So that long-term cost is paid for by the bones. And this leads us to a really important diagnostic challenge for clinicians, because you have to figure out what's really going on with your patient's bone health. So picture this. You've got a patient, you get a bone density scan back, and it shows low bone mass. Now what? Is this just straightforward osteoporosis, the thing we see all the time? Or could it be something else entirely, like osteomalacia? Getting this right is absolutely crucial, because the underlying problem is totally different. This right here is the heart of the matter. Think of it like this. Osteoporosis is a problem of quantity. You've permanently lost bone mass. The scaffolding is gone. The bone that's left is fine. It's strong, but there just isn't enough of it. Osteomalacia, on the other hand, is a problem of quality. The scaffolding is there, but it's soft and weak because it hasn't been mineralized properly. And take a look at this X-ray because it shows you exactly what we're talking about. In really severe cases of osteomalacia, you can see these things called looser zones. They almost look like fractures, but they're not. They're actually bands of that unmineralized soft bone. Seeing this is a huge classic clue that you're dealing with a mineralization problem. So beyond the X-ray, what are the red flags you should be looking for? Your patient might complain about a deep, achy bone pain all over. They might have trouble getting up from a chair because their big muscles are weak. And the labs tell a story: a vitamin D level that's in the basement, a high alkaline phosphatase that shows the bones are stressed, and lowish calcium and phosphorus. Okay, we've got the pathophysiology down. Let's switch gears and talk about the practical stuff. How do we actually approach this in the clinic? This is a really important question because the answer is not everybody. Routine screening of the general healthy population, it's just not recommended. We need to be smart about this and test the people who are actually at high risk, where finding a low level will change what we do. So who are these high-risk people? Well, it's a pretty logical list. Patients who already have bone problems, like osteoporosis.
people with low calcium that you can't explain, anyone with a condition that messes with absorption, like celiac disease. And remember that activation pathway? Skin, liver, kidney? Well, it makes sense that people with advanced liver or kidney disease are at super high risk too. And just to hammer this point home one more time, the test you're ordering is the serum 25-hydroxyvitamin D. And that number, less than 10 nanograms per milliliter, commit that to memory. When you see a level that low, your alarm bells should be ringing, and you should be seriously thinking about clinically significant bone disease like osteomalacia.
Okay, diagnosis is in. Now for the fix. Let's talk treatment, and I'm going to highlight a super important safety pearl that you absolutely cannot forget. Now, treatment isn't one size fits all. For your average patient with bone health concerns, somewhere between 1,000 to 2,000 units a day is usually a good place to start. But if you have someone with malabsorption or a patient with full-blown symptomatic osteomalacia, you're going to need to hit them with much higher doses at first to build their stores back up before you settle into a maintenance dose.
Okay, listen up, because this is probably one of the most important takeaways from this whole discussion. If you have a patient with osteoporosis and you're about to start them on a powerful drug like a bisphosphonate, you have to check their vitamin D level first. No exceptions. Here's why. Those drugs work by shutting down the process of pulling calcium from bone. If your patient is vitamin D deficient, they are depending on that very process to keep their blood calcium normal. If you block it without fixing the deficiency first, you can cause their calcium to plummet. It's dangerous. So always check and always treat first. You know, we've spent all this time talking about bones, but that's really just the beginning of the vitamin D story. There's so much research going on looking at its role in the immune system, chronic diseases, even cancer. So as we finish up, the big question is, what's next? What other vital roles does this hormone play in keeping us healthy? It's definitely a fascinating space to watch.